Thank you, Sri Bhushan, for those kind words. Respected chairpersons and dear friends, indeed it is an honor for me to deliver this oration in Dr. PATHROSE MATHAI. I had met him in, as Smita was mentioning, in 83 or 84 Southern Chapter Nephrology Conference. That was the first time he had set up a dialysis unit in private sector, probably first time in Kerala or in Southern India. And we were very surprised to see that a man has invested so much of efforts, money, dedication to set up a dialysis unit to take care of the patients with various renal diseases, especially in that area when there were a lot of cases of poisonings and snake bite and other cases. So indeed, it was a boon for the people in and around Kottayam to utilize the services of the dialysis facility set up by Dr. PATHROSE. He was a very affectionate person. We had so many interactions with him in various conferences. So I am very proud to deliver this oration in his memory. Obviously, we start this conference with a homage to one of our beloved founder member of our society, the founder of our society. All of us know a great academician, a great teacher, a good human being, and you would always see him in the first benches getting actively involved and asking questions to every presenter. So if you could answer Dr. Amarashan's queries, probably you had done your homework properly for your presentations. And certainly, I would like to pay my homages and remember some of my mentors. Dr. S.R. Rao and Narsingh Rao were my professors of medicine, under whom I did my MD medicine. And Dr. V.N. Wagre was a professor of medicine, but he was the first nephrologist from Andhra Pradesh to have gone down to Manchester to do his nephrology fellowship. After he came back, he did not take up nephrology, but Dr. Gopal Kishan also followed Dr. Wagre to Manchester. And after coming back, Dr. Gopal Kishan, all of you know, he is the founder, a doyen, a member for the establishment of nephrology in Andhra Pradesh and also in South India, and is a well-known figure all over India. Unfortunately, he is not here because of his ill health, but certainly I'd like to pay my respects to him. And obviously, nephrology is incomplete without mentioning my guru's name, Dr. Chuk, the father of nephrology, who was instrumental in probably establishing nephrology centers, trained doctors from all over India, and spread of nephrology all over India. He is one of the pioneer members of spreading the knowledge. So I pay my respects to my guru. Without him, probably I will not be known here. Obviously, before proceed, I would like to acknowledge the contributions and works done by other colleagues who have been associated with me in this journey. Most important and probably the top of the list is obviously Dr. Anuradha. We have been associated with over 4 decades now, and together we have been able to work in different, very friendly, very hostile, very difficult and all sort of situations. And we could, with support of each others and support of other staff, we could come out of this difficult journey throughout these 40 years. Dr. Ratan Jha was me in Medwin Hospital, where we could, a part of the study which I am going to discuss, he was actively involved in the academics, and he was also a very good academician, and he helped us in preparing the today's talk. And I would like to profusely thank Dr. Swarnalata and her team. Without pathology, we know nephrology is incomplete. So she and her team was responsible for extending all the support for our patients, and most important, my patients and my family. Obviously, when we talk about nephrology, the initial in 70s, the skepticism was, what is nephrology? It was all considered as everything related to kidney is urology. All cases of renal diseases, whether it is nephrotic syndrome or anything, would go to the urologist for a referral, and they did not know what is difference between nephrology and urology. And the awareness about the dialysis came in when, unfortunately, one of our senior leaders, Jayaprakash Narayan, fell ill, admitted in PGI, and then he was detected to have kidney ailment. And as usual, there were rumors and allegations in the press that the kidneys were damaged in PGI, and then later he was shifted to Bombay under our senior colleague, Dr. M.K. Mani. And when he was put on dialysis in Jaslok, there used to be a daily news item, and that's how the awareness of dialysis came in. So when Dr. Wagre motivated me to go to Chandigarh for nephrology, there were very few centers in India who were offering teaching facilities. There were good centers who were doing very good service centers, but teaching was limited to 1 or 2 centers. And I was lucky enough to be selected at PGI. And then that's how I entered in January 80, I entered into PGI. From there, you can say my difficult times or pleasant times or happy times started with my work at PGI. You know, it was an excellent center for academics. Punjab known for excellent food. Punjabis are very good friends. So I had the fortune to get all this while I was at PGI. But then I also had to deal with the sword of Sardar hanging over my neck for the next 2 years. So every day in PGI used to be counted, and every day all the residents would say, I have 122 days left. Other one will say, I have 82 days left. So that was our status in Chandigarh while doing our DM course. But once we came out of that, then we started to realize how important that phase was. We missed that academic atmosphere, we missed the work culture, and most important, missed the friends. The current senior nephrologist, Dr. Kasi is with me here, Dr. Vijay Kher, Dr. Sakuja, all these were my contemporaries, Ravinder Mehta. So these were my contemporaries, and we had an excellent working, and as a senior they guided me very well. So I had a very eventful stay at Chandigarh, including the way they supported me, because when I started in my posting in dialysis in Chandigarh, there was one unfortunate event of even an air embolism in the dialysis room. It was the presence of mind of my senior, Dr. Chabra, who helped us to solve this problem. Dr. Chug luckily had gone with Dr. Kasi to Trivandrum to attend an API meeting. So by the time he came back, everything was well settled, and probably never knew this unfortunate complication had occurred. And I was lucky. Otherwise, the return tickets were not easily available from Chandigarh those days to Hyderabad. And then the moment I entered into the dialysis, Dr. Kasi and some of the seniors handed over trocar and cannula to me, and the first thing they did in my posting was to make them learn how to put in a PD catheter. So that was being done with the trocar and cannula, and there was nothing like a PD catheter. The tubings of a drip chamber of the blood tubings that was used, holes made with the punch, and from those days we have been practicing Make in India concept, and that was used as a dialysis catheter for doing our peritoneal dialysis. Once you do the first puncture, then you are qualified enough to do a night duty in PGI. So the seniors would relax that a new Bakra has come into the department to take care of the duty hours. And obviously, those days used to have very large size dialyzer. I have not seen the rotating drum, but we have seen the twin coil Travanol dialyzer being used in Chandigarh. And then we came back later on in Hyderabad also. This was the Senti2, very popular machine those days. But if you see the picture in that frame, there was a panel behind which there used to be some carts, and we had become, as Dr. was mentioning, Dr. PATHROSE MATHAI was become an engineer. We thought all of us will be engineers that time, technicians. We would open up the panel and try to disturb the settings of the dialysis unit just to see that the patient dialysis is not disrupted and our dialysis schedule goes on well. And unfortunately, during one of these procedures, the settings were set so badly that we had a green light, but the patient was being dialyzed with very dilute concentrate, and the patient developed hyponatremia, and one of the patients unfortunately lost them. So that was the initial years where we suffered, where we had despair. We were happy sometimes when the patients got well, but we had to go through all this. So this was the shunt, as all of us know. But what is more important I wanted to convey was, this was easily used by some of our patients to commit suicide. The arterial and venous ends were, we have watched it while doing dialysis. They would pull it apart, and we have seen at least 3 patients we have seen who have committed suicide after pulling out these connections in the post-dialysis period while in the hospital garden or other place. Obviously, after the stent in PGI, a wonderful stent in PGI, I came back to Hyderabad, and then the long journey of nephrology problem and happiness started in Hyderabad, where we had everything had to be a challenge, right from the facilities of the laboratory, radiology. There were no X-ray films. X-rays used to be taken on a photographic plate, no ultrasound as usual, and the immunology service was utilized by KEM Hospital, Bombay, where we used to do HLA typing at least 10 days to 2 weeks before the transplantation, and then get the report and then plan for transplantation. And here I must acknowledge efforts put in by Dr. Gopal Kishan and the team and urology team, which made our transplant possible. And in that time in Usmania, lack of facility, we would use an IV cannula into the femoral vein and attach that rubber tubing for clamping it and use it for single-use dialyzer in the patient with acute dialysis requirement. So we were lucky that by 16th May, I came back in January. By 16th May, we could do the first transplant in Usmania with the support of the entire team, help from the government, and obviously the help from the entire staff and team. And this was the first team when we had a senior professor and surgeon and urologist, Dr. Shyam Sundar, who was Vice Chancellor, who is no longer with us. But you can see Dr. Gopal Kishan with him. Next to Dr. Gopal Kishan is our senior urologist, Dr. Ranganath Rao, was another adjoint in urology services, urology. Unfortunately, 5 members of this team are not with us today. We miss them, but they had made their mark in establishing the department of transplant in Usmania. Subsequently, few months down the line, Dr. Anuradha joined the department, subsequently Dr. Pradeep Deshpande, and then over a period of next 1 year or so, we had a fairly good established department for taking care of all the requirements. And these are the patients, as I said, who trusted us. This is the first transplant patient in Usmania, both the donor and the recipient. As we say, the longer the journey and the tougher is the journey, then the rewards are always, at the end, the rewards are very good for the entire team and for the patient. You know the progress of transplantation over the decades, right from the immunosuppression started, from surgical techniques and from the newer drugs, is a long journey. But obviously the introduction of cyclosporine was a turning point which made the transplantation possibly in our clinical setting. And that time itself we realized that a living related donor or a better HLA matched kidneys would have a better survival as compared to patients who were either unrelated those days or patients who did not have a good match even among the deceased donor and the living donor. And as the time passes on, all of us are aware that the gap widens between the deceased donor transplantation and the related donor transplantation, better matched kidney. But to our good fortune, with the available drugs and management, the half-life and the survival of the grafts have gradually increased, and now it has increased beyond 11 to 15 years for the deceased and the donor transplant. So overall, there has been a significant increase in the patient and graft survival over the decades. But despite all that, we come across data which says that the long-term patient survival has not been very good as per the expected lines. That means something down the line, we are missing something for the benefit of our patients. And this is just to show that the graft life has improved, both for patients who were doing very badly before the 1990s, before cyclosporine, but now in the present day, you are able to have an improved graft life. But as always says, these are all statistics. Statistics, as somebody had said, are like a bikini, which reveal is very suggestive, but what they consider is vital. And the most important information about transplantation is not usually available to us in the literature. And just to introduce, this is the first recipient which I had shown the first slide. Probably is the longest surviving recipient in India, is 42 years now and is doing well. So the question comes in, why some recipients do exceedingly well? What is that determines the longevity of the graft and the patient? Why some they do not reject the graft? How tolerance develops? Why don't we see tolerance developing despite so much of recent advances, so many studies for decades? We are not able to solve the concept of inducing tolerance in our patients. So obviously we lose the graft because of loss of graft function over a period of time. We use all of us know we use the general term of chronic multifactorial, multiple causes for this, and we have not been able to solve this problem of chronic. Can this process be halted or altered? That's what the efforts are on, and this highlights the various causes of long-term graft loss. If you see towards the end of the recurrence of the disease is one possibility which is not in our hands. Then chronic rejection because of the various immunological processes which are going on in the body, subclinical rejection, antibody mediated rejections which crop up. We lose a significant graft because of that. But what is important, I thought I will highlight is the CNI toxicity. Although this is a highly debatable topic, very few people agree with this in the literature, but all of us realize, and even in patients who have non-renal grafts, they lose their kidney functions possibly because of chronic CNI use. So we thought this is one important aspect which is potentially if not totally treatable, at least we can slow down, or with that in mind, so many efforts have been made for the last 30 years to either minimize or withdraw CNI over a period of time. And all of us know that in 90s, for economic reasons and for the fear of nephrotoxicity, we would withdraw CNI within the first few months, 3 months, 6 months, 1 year, depending upon the different protocols of the various centers. There is a long list of calcineurin inhibitor toxicity, which is probably no need for me to go into these minor details. But from the point of view of clinical outcome, both tacrolimus and these are all equally responsible for the chronic toxicity, and multiple events are responsible for the chronic cyclosporin toxicity, and it ultimately results in interstitial fibrosis, the typical striped interstitial fibrosis, arteriolar hyalinosis, which is reported by most of the pathologists, then some global glomerular sclerosis in the biopsy specimens, focal segmental sclerosis. Ultimately, we realize that none of these lesions are specific. It's a combination of various inserts which results in the long-term consequences of CNS use. So it is clinically and histologically, it is very difficult to differentiate chronic allograft nephropathy or other causes from the cyclosporin or CNI toxicity. So there are a lot of articles which say there is no need to continue. In fact, there is a harm by continuing cyclosporin beyond the first decade, because the benefit which you want to derive of CNI use is over by the first decade, and there is no need to continue. But there are already so much of data available, conflicting data, which says that if you withdraw it, then there is a risk of graft loss, and you cannot manage this patient without CNI. That's why standard all over the world, almost 80 to 90% of the patients still maintain a CNI based regime for long-term immunosuppression, although isolated reports are there of either 2 drug or an additional drug and newer drugs. But CNI remains the cornerstone of our treatment for the last so many decades. The problem comes in if we don't understand whether CNI withdrawal or CNI will control the long and ongoing antibody mediated rejections, subclinical rejections, and in absence of CNI, will these rejection processes, immunological processes get worse? So with that difficult, I thought I'll just start the other part of the discussion with a small case. This is a 20-year-old boy, biopsy proven FSGS, Within 1 year, he lost his he lost his renal functions. His father as a donor, we did a transplant in 2007. And then when we had warned the family that there is a high risk of rejection in him, a high recurrence of him, because of biopsy of FSGS, he had lost his kidney within 1 year. So anyhow, the boy did very well, as usual on 3-drug regime, and when towards the follow-up, towards the end of 2015, beginning of 2015, almost 8 years after transplantation, his creatinine started increasing, 8 years. And then when we reached around 1.7, 1.8, when we did the graft biopsy, the tacrolimus was slightly on the higher side for that 8-year period. We did a graft biopsy, and the graft biopsy was reported from Apollo. They reported that looks like there is a lot of interstitial fibrosis. There are some TMA changes in the glomerulus. There are some arterial hyalinosis also. He said, please exclude CNI toxicity. So we took the decision to taper off and stop his CNI and continued his MMF and prednisolone with slightly enhanced dosage for the next few weeks. And then again gradually we do the tapered off the steroid and MMF dose. And this boy is on follow-up for almost another 8 years now. And you see that in follow-up over the last so many years, 104 months, almost nearly 9 years now. After the withdrawal of this, slowly the creatinine is coming down, GFR has improved, and his last follow-up, the creatinine is still very much within the so-called normal range, and GFR is still maintained, indicating that withdrawal of cyclosporin or tacrolimus in him has helped him in maintaining his graft function. And I saw him about a month back, still maintaining fairly good renal function and still doing well. So, with this background, we presented our data in the World Congress of Nephrology with Dr. Jha as my other author and Dr. Anuradha's help. We presented this data and we said to try and present our data of withdrawing cyclosporin or CNI within the first year or second year or later on in the course of the disease. So during this period, we had done transplants to about 328 patients with 328 transplants in 322 patients. As usual, they were initially on 3 drugs. Some patients did receive induction, but finally they were mostly on 3 drugs. And then after informed consent, for financial reasons, this started in 1990s. For financial reasons, the CNI was withdrawn in 6 patients in the first year. So out of this 22 patients in whom it was withdrawn, 6 patients with this were divided in 3 groups. In the first group, there were 12 patients in group 1. There were 2 patients in 12 to 24 months. In second year, another patient, some patients, the CNI was withdrawn. And in late follow-up, we had to withdraw CNI based on the clinical outcome. So we realized that in 6 patients in group 1, 12 in group 2, that was in the second year. And what is important I want to highlight here is 4 patients where it was withdrawn as late as 10 years after transplantation. And if you see that, the mean follow-up is not less than 200 or 180 months after CNI withdrawal. There were no rejections episode, that is important I wanted to highlight. And when we see the graph and follow-up of the GFR, we realize that in the group 1, when it was withdrawn within the first year, a fairly good maintenance of GFR and creatinine over the next follow-up of almost 7 to 12 years. And some of the patients are still on follow-up with us with maintained renal functions. Then in the second group, we see of the 12 patients, 2 patients did lose their graft, but some of the about 8 or 9 patients were doing very well, almost a mean follow-up of about 180 months, indicating that they could withstand the CNI withdrawal without any major adverse effect. You can see that the GFR has improved, serum creatinine started coming down and remains maintained in so many months of follow-up. And what is important is this remaining 4 patients who develop increased creatinine towards almost 6 to 12 years after the transplant. and when the creatinine went up, we again did a biopsy for these patients, and all these patients without biopsy we did not take any decision. After biopsy, when the pathologist said that there is no evidence of immunological problem, no rejection, and the features are suggestive of a CNI toxicity, we took the decision of gradually withdrawing CNI in all these 4 patients. And when we followed up, you will be happy to see this graph, that over the next mean follow-up of almost 180 months, these patients have had a well-preserved GFR and a relatively stable or slightly lower creatinine when the CNI was withdrawn. So indicating that CNI withdrawal clinically has certainly helped this patient to maintain their renal functions. Obviously, when you look at the complication, when you have such a long follow-up, the longest survival or follow-up is almost 29 years, and the shortest was about 8 years. So if you look at this follow-up, there were 3 patients who died of, unfortunately, of carcinoma tongue. This we reported in the Indian Journal of Nephrology, that the malignancies in our transplant follow-up. And out of these, 2 patients were only on minimum azathioprine and prednisolone. Still, unfortunately, they developed malignancy. Some patients had a antibody-mediated rejection much later in the course of the disease. One patient had a CVA, other few patients died of infection. So a mean follow-up of almost 200 months, there were about 9 deaths for the various causes which I had depicted it here. At the end of the last follow-up, which we did somewhere at the end of our pandemic, COVID, we realized that 13 patients were still alive. The average survival was of anything from 12 to 29 years. The serum creatinine was well maintained, the highest being only 2.3 in one of the patients, and the GFR was well maintained. The lowest GFR we could get in one of the patients was 47 ml in the third group, where they already had developed graft dysfunction, and then we started to withdraw cyclosporin or CNI in that group, and there was not much of proteinuria, and there was no. So in the end we decided, and we conclude, that not all late graft dysfunctions are irreversible. Benefit may occur even after late withdrawal, sometimes years after transplantation. But before taking a decision, graft biopsy is absolutely essential. I think nobody will venture to stop this drug without documenting that there is no ongoing immunological process in the graft. And then we thought that in live-related transplant, especially in our group, in our study, those who did not have rejection, that is important, that who did not have rejections in the first 1 year and subsequently in the follow-up, that was the patients whom we had selected for CNI withdrawal. And in these group of patients, they were well-matched kidneys, related donors. And in these patients, we tapered the CNI gradually over 7 to 8 weeks, and then stepped up the dose of steroids. And they are on regular follow-up. So my way of looking at it, our way of looking at it from Medwin Hospital, and this was that it is never too late to withdraw CNI if you have a good documentary evidence that this could be the culprit for some of the failing grafts. So these are some of the references. So I thank organizers for giving patient hearing, and in the end, certainly I would like to quote our great scientist Newton, who said he feels like a small child picking up pebbles at the seashore when the vast knowledge of ocean lies in front of him. He is very happy with a small few pebbles on the seashore. So with that, I would like to again thank the organizers, everybody, to give me and deliver lecture in this oration. Thank you. Thank you.